Hi, I'm Dr. Seth Sherman from Stanford University, and this is a case presentation evaluating two-stage revision ACL reconstruction. The patient's a 37-year-old female. She's a recreational athlete. She had a non-contact ACL injury. She underwent a primary ACL allograft reconstruction with partial meniscectomy at an outside hospital. She had insidious recurrent instability and pain beginning a year and a half later prior to presentation in my office. While seeing me, she had range of motion that was 10-0-140, so 10 degrees of hyperextension, which was symmetric. She had a 2B Lockman and what we call an explosive grade 3 pivot shift. She was stable and symmetric to varus and valgus stress, her dial test was symmetric, and her opposite knee had a physiologic pivot glide with an intact ACL. On her preoperative x-rays that are weight-bearing, we can see that there's no significant joint space narrowing. There's concern for significant cystic changes in both her tibial and her femoral ACL tunnels. We always get other views, including long leg mechanical axis, which in this case show neutral alignment, and we do weight-bearing lateral x-rays of the knee and/or tibia to evaluate for tibial slope, which in this case on x-ray was measured to be 13 degrees. We have MRI, which showed intact menisci, collaterals, and cartilage, but obviously those dilated cystic femoral and tibial tunnels. We do like to do 2D, 3D CT scans in these challenging cases to evaluate both for tunnel widening and tunnel positions. In this case, these tunnels were obviously wide and above our thresholds, but the tunnel positions were good, and the tibial slope was measured at 12 degrees. Other information that's critical is to think about and to rule out infection. She had no fevers, chills, or sweats. Her vital signs were stable. Her wounds appeared benign. She had an infectious workup, including aspiration and culture. She had laboratory values, including CBC, ESR, CRP, which were negative. And we also look for and think about this intraoperative in our first stage of our revision reconstruction. Arthroscopically, when we got in there was mild synovitis, no signs of infection, and really minimal chondrosis. She had intact medial meniscus root. We always have to look for ramp lesions in these complex chronic or salvage cases. Lateral meniscus had only a white tear with an intact root as well. Here's a look at the femoral tunnel, which was measured to be 14 millimeters, and the tibial tunnel diameter was measured to be 16 millimeters. It's always useful to make a problem list. So here we have our 37-year-old. She's a recreational athlete. Insidious failure of her prior ACL allograft. We think to ourselves, why did this fail? What can and should we do different this time around? Is it graft choice? Is it issues with her tunnel? Is it underlying hyperlaxity, missed malalignment, meniscus deficiency, other, or combination of all these factors? Should we do a one-stage versus two-stage? If it's two-stage, what bone graft are we using? What concomitant procedures might be helpful for these other structures? And of course, setting goals and expectations in rehabilitation and recovery. For this lady, we moved forward with a two-stage solution, given the size of her tunnels. We can see here in the first stage, we use the cannulated revision allograft dowels. We can mallet them into final position, and then I find it very useful to power rasp, and we can contour them so that they are flush to both the femoral and tibial aperture. Can see here that these allograft dowels are soaked in bone marrow aspirate concentrate. We have a separate video showing ways that we can take bone marrow aspirate from the distal femur and or the proximal tibia, or of course, if it's your preference, you can go upwards towards the hip. I think it is also helpful to consider, as we see on the far right, mixing AlloSync Pure with bone marrow aspirate concentrate. If there are any gaps in your bone grafting or severe enlargement of tunnels, even larger than our biggest dowels, then we can fill those gaps and seal the apertures more precisely using this AlloSync Pure mixture. And so here we see our final fluoroscopy after the bone grafting of both the femoral and tibial tunnels. For me, I like to weight bear as tolerated. They can bend the knee as tolerated with a functional brace. I typically track these by x-rays. Rarely do I use CT scans in the case of these allograft dowels, and I usually can return to the operating room as early as 3 months for my second stage reconstruction. In this scenario, we're moving towards a revision ACL using quadriceps autograft and a lateral extra-articular tenodesis with iliotibial band autograft. Some tips or pearls that might be somewhat different than others. I like to do a paratenon sparing quadriceps harvest, so I can use the Quad Pro similar to how the technique is demonstrated, but I leave that most anterior aspect of the paratenon intact. This allows me to go full thickness with my graft, but I really have very little to close, and it maintains continuity between the medial and lateral aspects of the residual quadriceps, as you see here. Here we can see preparation on the back table of our quad link with internal brace. I am always soaking in vancomycin, and I'm always pre-tensioning my graft on the back table before bringing it towards the patient. Another tip or trick for doing ACL and LET to avoid crowding of those tunnels. Here you can see we're using a 2/6 knotless fiber tack. And what I wanted to point out is where the arrow is. I'm leaving my femoral pin in place while I'm placing the fiber tack. That way, if there's convergence, I can just redirect. I make sure that my soft suture anchor is well positioned and firm, and then I can pass my femoral shuttle stitch. This alleviates a lot of anxiety in the operating room for me. You can certainly also look with the camera arthroscopically through the medial portal into that femoral tunnel to ensure there's avoidance of that fiber tack at this step. And then otherwise, we do the IT band tenodesis as shown here. This is the final revision quadriceps autograft with physiologic tension without graft or notch impingement throughout the range of motion arc. Some things that I consider when planning these difficult two-stage revision ACL reconstructions. The first, as we mentioned, was thinking about tunnel and tunnel diameter and position. We use the 2D CT scans to quantify tunnel enlargement, typically using 14 millimeters as our cutoff for action. Here you can see why the 2Ds are quite useful for this purpose. We use the 3D reconstructions a bit differently. We really are looking for tunnel position. We can overlay the Bernard-Hartle grid if you so choose, and we can envision a couple of different scenarios, like this case where the tunnel is not terribly wide and in good position, and we can do a single-stage revision reconstruction. However, there are other cases, like this one, where that prior tunnel is way out of the anatomic position, and we can clearly and easily do anatomic ACL reconstruction in one stage. However, there are other times where we require either single stage with some tips and tricks like larger bone blocks or blocking screws, and that can get technically difficult. Or we can lay up and do a rational two-stage solution like the case that I showed today. Another tip or trick that I think is important is graft choice for revision. I almost exclusively am using autograft, and I think quadriceps have begun to really become the mainstay of treatment for me for these types of scenarios. In this paper, autograft is 2.8 times less likely to rupture with superior subjective scores and activity scores at 2 years. So please consider autograft revision if you can. Here, there's obviously a growing set of data for quadriceps autograft, not just for revision ACL, but also for physial sparing ACLs and also for primary ACL, which rivals our gold standard other grafts choices such as BTB. We always want to evaluate and protect the ACL graft by preserving the meniscus if at all possible. In this case, we did not have roots or ramps or complex meniscus tears to go by, but certainly we want to err on the side of meniscus preservation. It can only make your outcomes better. We all know about the clinical relevance of tibial slope. The first step is to measure precisely and to understand our cutoffs, which are about 12 degrees, where slope might become something that we consider fixing or using as a modifiable risk factor, and perhaps if you're on the fence, adding something like a lateral extra-articular tenodesis to your revision or primary ACL. Here is how we can measure the tibial slope on X-ray and or MRI or CT with that 12 cutoff. And then lastly, we're thinking about anterolateral rotatory instability, and we're thinking about ways to protect our ACL outside of the joint. There is a very strong evidence base now for adding lateral extra-articular tenodesis. The workhorse is using iliotibial band autograft, and I use that generously in patients with many risk factors and certainly in the revision setting. So I thank you very much for your attention, and I hope that this case presentation on two-stage revision ACL reconstruction will bring up some tips, pearls that are useful for you in your daily practice.